cancer. Renal cancer, keep in mind, kidneys are very vascular as well. And so one thing that happens with our renal cancer as a whole, a lot of times, renal cancer is cancerous. When they say that a patient has something going on renal-wise, it's very rare for it to be benign. And the reason why is because it's so vascular and so full of nutritional stuff, right? 85% of the time it's malignant. So that's a very high percentage. Usually it's a renal cell carcinoma or adrenocarcinoma. And adreno is actually the most common of the renal cancers as a whole. So etiology-wise, there's an increased SUD rate. The SUD rate's increased. Anemia, but we just said those patients have renal failure have a higher chance of being anemic as well. Weight loss, fever, hematuria. It's not normal to have blood in the urine. Flank pain, and then the flank pain will vary depending on the size of the growth as a whole. So you always have to remember, urinary output equals cardiac output, so we want to see at least those 30 mLs of urine. Complications, all right here. So all self-explanatory as a whole. Again, very vascular, thromboembolism because of where it's at, more susceptible, infection, and then of course atelectasis. Because it's so close in proximity, they're not going to want to take that big deep breath and cough. So we know it's a spirometer and we know splinting already. So that is very important when it comes to this. Considering if you think of it as your kidneys are still located in your torus, right? Or torso. In your torso, it's not a bull, okay? But in your torso, that's still abdominal-ish surgery, even though, granted, it's on the side. However, it's still considered more susceptible to patients that could have atelectasis because of that deep cough. Haley, is that your hand up?
Yes.
Okay.
What were the two types of renal cancer? I had the adenocarcinoma.
That's one, and the other one is renal cell carcinoma. And then our adrenal is the most common.
Thank you.
You're welcome. So during surgery, pre-op, same for everybody, of course, getting the whole assessment history, all of that we already would have. So just a picture of what renal transplants look like is they remove the kidney, but you notice they connect everything to the new kidney. Just a visual, they put it in the iliac crest for anchorage because they won't have any ligaments or tendons holding it in place, right? And so they use the iliac crest to hold it. I mean, lack of a better word. So, again, complications, all that follow with renal transplants as well. ABC is important. Pain relief is important with these patients. Splinting, as we mentioned, early ambulation, get them up and moving early is a key. But that is across the board. You can't go wrong with questions like that. You want them up and moving to prevent the atelectasis, to prevent the VTEs, all of that. Patient teaching, any drainage devices, more than likely may have maybe a JP and or hemovac, depending on what the physician or how much drainage was during surgery and how much the amount is going to be. And then of course health promotion and screenings and things like that. Questions about any of that renal stuff? Yes?
Do we need a renal transplant the almost days?
They remove it.
Okay.
Yeah, they remove it. That's kind of why it's kind of looks
Sounds like
yeah, no, it's disease, you can take it out. But that's why it's
Faded
like
out.
color faded, good word, faded. Okay, urinary is gonna go very quickly. So with urinary diversions and urinary work,